Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are again with Jason Jarvis, who is our tropical medicine expert on our faculty. He has his MSc in infectious disease from the London School of Hygiene and Tropical Medicine, and currently writing his doctorate. Jason, welcome back to the program.
Thanks. It's good to be back.
So tell us about what you have planned for this malaria deep dive.
Yeah, so what I found was an article in a journal called Malaria Journal. This was published recently, and it's talking about, so the title of this is A Perspective on Oxford's R21 Matrix M malaria vaccine and the future of global eradication efforts. So this is the newest malaria vaccine. There's two of them currently out. There's the RTSS that came out about 4 years ago or so, and now we have the R21, which is it's a very similar. It's based on a very similar technology, although it is definitely more effective than the original RTSS. But maybe for our listeners, we could just start with a talk on the malaria life cycle and what this disease entails.
Sure. So what is malaria?
Well, so malaria is a parasitic infection, and the word parasitic has a lot of different connotations. In the strictly speaking, you could say that viruses are parasitic and bacteria are parasitic, at least the ones that exploit the human host. But in medicine, when we're talking about parasites, generally what we're talking about is a eukaryotic animal, so to speak. We're talking about things like tapeworms, intestinal worms, Giardia. So these are complex organisms that are included within the animal branch of biological taxonomy. So protozoa are single-celled organisms that are considered animals, so that you can think of them as almost like giant bacterial cells, but they're much more complex than bacteria, and they certainly have a lot of different complicated life cycles. So parasitic protozoa are generally divided into four different branches. You've got the Apicomplexa, which are the malaria parasites, along with things like Cryptosporidium and Babesia protozoa. You have Mastigophora, which are the flagellated protozoa. So that would be things like Giardia and Leishmaniasis and African trypanosomiasis, African sleeping sickness. You have Ciliophora, which are ciliated protozoa. So there's really only one organism in that class that really is an issue with humans. That's your Balantidium coli. And then the fourth category are the amoeba type protozoa. So that is your Sarcodinas, and that includes things like amoebiasis, or Entamoeba histolytica is the technical name for that. So anyway, that's kind of where malaria fits into this overall picture. Some of these protozoa are, some of these protozoa are vector transmitted, so they come from various insects, typically, or from ticks. And some of them don't rely on an insect vector. So the ones that don't rely on an insect vector are going to be a lot more widespread. So that's your Cryptosporidium, your Giardia, your amoebiasis, where you get it from just drinking unfiltered water. Whenever you have a parasite that's vectored by an arthropod, such as a mosquito or a tick, those protozoa are going to be constrained within a geographic area. So, for example, in the case of malaria, you need the right species of mosquito. You need the Anopheles species mosquitoes, which are fairly prevalent worldwide. So in the case of malaria, the mosquito doesn't tend to be a big restricting factor. The restricting factors are going to be more factors along the lines of your healthcare infrastructure and things like that. Whereas in the case of American trypanosomiasis, that's only going to be naturally acquired in Latin America, so Central and South America, where you have the reduvid bug that transmits that. So getting back to malaria, again, this is a apicomplexan protozoa. It's vectored by the female Anopheles mosquito. And this is a mosquito that takes blood meals, usually in hours of darkness. So anytime from evening until sunrise, you have these mosquitoes out on the prowl, so to speak, looking for blood meals. So anyone that's out during that time with unprotected skin, so if you don't have clothing over that skin or insect repellent, those mosquitoes are going to want to take a snack from that person. And that's why we really stress the use of insecticide-treated bed nets anytime we're sleeping in the tropics. So if all of those defenses are not working, then the female Anopheles mosquito takes a bite and, or I'm sorry, she takes a blood meal. They're not technically biting through the skin. So the proboscis of the mosquito goes through the skin, finds a capillary. They have different ways of finding capillaries. It's it could be a whole other topic here. And before the female Anopheles begins taking the blood meal, they actually inject saliva. So the saliva that they're injecting has three purposes. One is there's an anesthetic property, so that the victim doesn't notice that they're getting the bite. Number two, you have a vasodilation effect with that saliva, and then number three, you have a protein in the saliva that also creates an antiplatelet effect, so that the blood, or an anticoagulant effect. So there's lots of blood to take from the blood meal, and that's the purpose of the saliva injection. Now, if the mosquito happens to be infected with malaria, the malaria stage that is infectious at this point, these are called the sporozoites, and they reside within the salivary glands of the mosquito. So that's what evolution over millions of years has figured out here. So sporozoites enter the bloodstream with the saliva, and the sporozoites enter the bloodstream and they make their way to the liver. Generally, that's within 30 to 60 minutes. Sorry. And you have on average anywhere from about 50 to 100 sporozoites per blood meal. The vaccine that we're going to talk about today, R21, is formulated to target this stage of the infection. Once this parasite's in the body, it's quite elusive, and it has different stages within the body. And the one that is the most vulnerable from a vaccine development standpoint is this stage here, where the sporozoites are coming in and finding that liver. All right, so the sporozoites enter liver cells. They go into the hepatocytes, and this stage is referred to as either as the liver stage, or the more complicated term here is it's the exoerythrocytic cycle. So this is something that's happening where you're having a multiplicative cycle outside of the bloodstream. So the infected liver cells so the parasite in the infected liver cells are essentially walled off from the immune system by way of the liver cell membrane. So the immune system doesn't necessarily see them at this stage. The cell is not putting out any kind of antigenic markers that would attract the attention of antibodies or anything like that. So over the course of generally about a couple weeks, the infected liver cells basically turn into little malaria factories, and these stages are called schizons. And once the schizon form of the infected liver cell reaches maturation, it ruptures and it releases somewhere on the order of 10,000 to 30,000 malaria parasites. And this next stage of these parasites are called merozoites. The merozoites have surface antigens that are highly variable and essentially are able to evade immune detection because there's so much variation in their surface proteins. So this makes it really hard to kind of attack this stage with vaccines. In addition, the merozoites are in circulation for a very brief period of time, so there's very little chance for the immune system to kind of notice them and begin eradicating them. So on to our next stage here. Merozoites go ahead and they invade red blood cells in circulation, and then just as in the hepatic cells back in the liver, the infected red blood cell will eventually become a schizont, which is just sort of a shorthand way of talking about it as a malaria factory, if you will. So initially, the infected cell would appear in microscopy as a ring stage parasite. Right, so it actually looks like a little ring inside the red blood cell, and as it matures, kind of the midway stage, it becomes what we call a trophozoite. So there's a little bit more detail in the red blood cell if you're seeing this on microscopy, and then eventually you've got a full-blown schizont where you've got generally anywhere from 8 to 12 merozoites within that cell that you can see on microscopy. The erythrocytic cycle, the red blood cycle that we're in now, usually takes anywhere from 2 to 3 days to complete. And once these schizons rupture, you've got, again, somewhere between 8 to 12 merozoites coming out, and they are just repeating the process of infecting new red blood cells and carrying on the life cycle. Now, if this was all that the parasite did, this would basically make your human host a dead-end host. So far there's no way to transmit this to another mosquito. However, going back to the early stage of the red blood cell infection within the red blood cell, back to that ring stage, some of the ring stages do differentiate into gametocytes. So the gametocytes are the male and female versions of Plasmodium here, Plasmodium being the malaria genus. So you have male and female gametocytes, and they don't necessarily interact in the human host. They're just in circulation, awaiting uptake by another feeding mosquito. So another female Anopheles mosquito comes along, takes a blood meal, and incidentally ingests some of the gametocytes. And as long as there's at least one female and one male, those two gametocytes will pair within the gut of the mosquito, and they then turn into a ookinete stage parasite, which then burrows through the wall of the mosquito gut, turning into an oocyst. The oocyst turns into essentially a sporozoite factory in the way that we saw with the schizont. So once these oocysts are mature, they rupture, releasing sporozoites, which then make their way down into the salivary glands of the new mosquito, and then that's the complete life cycle.
So that's a fantastic PhD level review of malaria. And I like to think of this more as since I'm a knuckle dragger. So the mosquito bites you, puts little wee beasties in. Wee beasties are quick little buggers. And within a minute, they hide in the hepatocyte and they just stay there and they multiply and they make a bunch of little buggers that are called little round merozoites. Those guys leave the liver, go and find a red blood cell, and they just make merozoite factories. And they do it again and again and again until there are so many merozoites floating around that you get a fever. That is when your immune system is looking at these little round merozoites and saying, good God, there's loads of them. And how about we start the immune system and have a bit of a fever? Your patient's going to have a bit of clinical signs of something's wrong with them, fever of unknown origin. And those buggers are going to continue making more and more and more red blood cell factories. And some of them are going to decide to turn into male and female gametocytes, which then get sucked up by the mosquito, which after that, I don't care. I'm just looking at what is happening in my casualty. And so sometimes there's tons and tons of little wee beasties called merozoites floating around outside of the red blood cell, trying to find more blood cells to infest. And that is when we have our fever. So sometimes you have a fever and sometimes you don't. Why is that?
I guess the main difference in symptomology with your malaria infected patient, it really depends on past exposures. So let's say you have a 15-year-old person in Africa who's had malaria several times in their life. So they obviously they have survived their previous malaria encounters, and like just about any infectious disease, if you survive the infection, the immune system remembers that infection mainly in the way of your B cells. So you now have antibodies to combat future infections. So that type of immunity is not 100%. So essentially, the 15-year-old African with previous exposures, when they get subsequent malaria infections, the symptomology, not always, but it tends to be quite benign. So they typically won't be, an inpatient in a hospital or something like that. It'll present more along the lines of flu-like symptoms in people that have had malaria and have survived that encounter. And that's because their immune systems are already primed for this infection. Now, that type of immunity does not last very long. So if your 15-year-old native African moves to the UK or the US or somewhere where there's not, they're not getting exposed to malaria, I'm not sure what the timeline is, but if that person goes back to Africa, say 10, 20 years later, they will generally have lost all their immunity, and then they're going to respond more along the lines of someone like you or myself, who have never had a malaria exposure that we know of, and so the people that are malaria naive, where the immune system has never encountered this infection or it's forgotten because it's been so long since the last one, those patients tend to go. Those patients tend to become clinically severe very quickly. They might. You might see within a day or two them entering almost like a sepsis-like state, where they're manifesting severe signs of malaria. So you're looking at altered level of consciousness. You're looking at acidemia, hypoglycaemia, and of course the classic malaria sign, which is fever and chills, or what we call rigors.
So so we have malaria, just your normal malaria casualty, and then there's severe malaria. So what clinical sign can we see to know that my casualty, who is rigors, who has shivering, has moved from just a normal malaria to severe malaria?
So that's a good question. So there's a lot of, it's like a lot of things in medicine where a disease can give you a whole constellation of symptomology. So what I've read in the literature most frequently, as far as the differentiation between benign and severe malaria, is your patient's ability to swallow a pill, and that's a I guess that's as good a sign as any, because if the patient's able to swallow pills, then the recommendation is we'll start treating them with atovaquone proguanil, which usually goes by the trade name of Coartem. And so that's going to be our mainstay treatment for benign malaria. There are other drugs out there that can be used. You have all of your quinine, chloroquine type derivative drugs, and they work in some parts of the world. Other parts of the world, there's resistance to these drugs. So the premier drug currently is the atovaquone proguanil, also known as Coartem. If the patient is unable to swallow a pill, as in they are severely obtunded and probably are looking a bit septic or a lot septic, then we say, well, that's severe malaria, and then we'll go in with a artemisinin based drug, and that'll be IV or IM, as the case may be.
So is that the nuclear option, the artemisinates, just going to sort everything, is it?
That is the premier drug currently. Again, there are other options out there that are probably cheaper, and malaria tends to be very regional as far as what drugs work, what drugs don't. If you're able to detect it with a rapid diagnostic test or not, or if you might need a certain rapid diagnostic test. So it's a complicated problem, and the research is ongoing.
So you mentioned RDTs. So there's a few different ones out there, and they look at different things. So what if I'm going to give this casualty an RDT? How successful is it? How accurate is it? And what different types of RDTs do I need to look at for different types of parts of the malaria merozoite?
Yeah, so there are at least dozens of RDTs out there. The World Health Organization every several years they do publish a very long pamphlet on their results of the trials of the different RDTs. So that's something that the listeners can look at, especially if they're going into a particular place, Paraguay or Zimbabwe or Laos or whatever. You're going to have different RDTs that you want for those different geographic regions, and the WHO is a really good resource for looking at that prior to travel to those places. Your RDTs are going to be upwards of 90% specificity, sensitivity, and I think the main issue right now with the RDTs is classically they have been based on the HRP2 or the histidine-rich protein 2 surface antigen that you find usually on Plasmodium falciparum malaria, which is the one that we're most concerned with globally as far as causing the most deaths. So what you have is you have an evolutionary pressure on the malaria that presents with HRP2 on the surface. Well, if those are all getting eradicated, then if you by happenstance have mutant species that come along that are not displaying the HRP2, well, then those don't get detected, and those are able to survive and carry on. So that's one of the main issues right now with RDTs, the rapid diagnostic tests, is in some parts of the world the HRP2 detecting RDTs are not working very well. They're gonna give you a negative result because the parasite that you're looking at does not display that antigen. So the alternative to the HRP2 RDTs would be something that's looking at PLDH. So that's parasite lactate dehydrogenase. So that's going to be an alternative in many parts of the world where the HRP2 is not going to work.
So does that mean it's a 90% success rate? So I've got an RDT, Binox now, since it means everywhere. And so if that's a 90% chance of success of finding malaria in my casualty, and they look at the HRP2, shouldn't I have two different types of RDTs, one looking at each of them?
Yeah, I think that would be good policy. You know as well as I do, particularly in the field environment, we want a backup option to everything. So if it's like when we're dealing with advanced airways, like, well, if I can't intubate this person, then I've got an eye gel here, or and those kinds of things. So yeah, I think it's worth having two different RDTs for that reason. And I would say if your patient is exhibiting classic signs of malaria and you run an RDT and it comes back negative, I would retest that blood. If the patient is just exhibiting flu-like symptoms and you happen to be in a malarious area and you run the RDT and it's negative, that's a bit more believable as far as is that a true negative test. And again, this technology is not 100%. So even if we run negative RDTs, we still want to keep malaria in our differential diagnosis. We might demote it down our differential list, but we don't ever want to exclude it because we're dealing with diagnostic technology that's not 100%.
So let's say I'm going downrange and I have one type of malaria RDT that just looks at the HRP2 and it comes up negative, and there's a 10% chance the man has malaria. Can I not just whack in some coartem anyway?
That might be something that you could do. And it depends on your risk aversion, pros cons, right? Yeah, that's just something the provider is going to have to think of on the spot, I guess.
That's something. Telemedicine is great for that, isn't it? You can do a bit of a top cover to see, he's just not doing well. It came up negative. Should I just go ahead and crack on with coartem?
Absolutely, absolutely. And the RDT is not the only technology out there. You have the remote practitioner may or may not have the gold standard technology, which is microscopy. I know not everyone's going to lug a microscope around in their travels. If the microscope is not available, then the other thing that we can do to look at diagnosing malaria, if the person has a ophthalmoscope, which is much smaller than a microscope, and an ophthalmoscope is probably something you want to have anywhere you go. It's a good thing to have. Just in general, they're very lightweight, much less expensive than microscopes. So if you have a suspected malaria patient, particularly a cerebral malaria patient, which is one of the manifestations of severe malaria, if we're able to dilate that pupil out and get in there and look at the retina with the ophthalmoscope, that can help our diagnosis of malaria.
So that shows up as white spotches, doesn't it?
Yeah, exactly.
So it's important for the remote provider to have experience with the ophthalmoscope for a normal back of the eye. So when they do see white spotches, they can differentiate between or I guess just look at two of them. Look at somebody who's not presenting with signs and symptoms of malaria. Look at the back of the eye, get an idea what a normal one looks like, and then have a look at the one where you suspect of malaria. So another thing about malaria, there's tons of different fever cycles. So malaria could have fever spike every day, every 2 days, every 3 days, 4 days. What can you tell us about that?
Yeah. So going back into the life cycle, if we look at the erythrocytic cycle, which is the cycle that is occurring in the red blood cells and what's creating the symptomology, and may ultimately kill the patient if you lose enough red blood cells, you're becoming more and more anemic, and that can be life-threatening, of course. At the same time, the Plasmodium falciparum, malaria, has a way of sequestering itself into small capillaries to avoid clearance by the spleen. And so one of the things that makes this lethal is you get all these capillaries in the brain clogged up with parasitized red blood cells that are hiding out from the spleen, and now you're getting less circulation to important parts of the brain. So going into the fever cycles, the red blood cell cycle is generally 2 to 3 days, depending on the species, right? And so we've got four human species that are considered the classic human malaria species, and then we've got an additional one that is it's a pretty common crossover from monkeys in Southeast Asia. That one is Plasmodium knowlesi. So Plasmodium knowlesi and Plasmodium falciparum tend to have a 2-day erythrocytic cycle. So what you're going to see there is you're going to see a fever on day 0, basically. So these all start with day 0. So a fever on day 0, and then by the time you get to day 2, then you're seeing that fever spike, right? So that's called a tertiary cycle. So we're seeing it on day 0, and then on day 2. You can have a quaternary cycle, which is day 0 and then day 3, and that's only with Plasmodium malariae. Plasmodium vivax and ovale generally are less severe in their symptomology than Plasmodium falciparum, and they also will generally exhibit a tertiary cycle. Plasmodium falciparum commonly will you'll get two tertiary cycles that are going kind of out of sync with each other. So what you get is a daily fever spike with you can see this with both Plasmodium falciparum and Plasmodium knowlesi. So the patient has their sort of state of normal thermia, maybe some chills, but then reliably every 24 hours or so they're getting this big fever spike as one of the two cycles ruptures out of the schizonts in the red blood cells and goes on to infect more red blood cells.
So we can look at the RDT. We can look at clinical to see that they're clinically unwell. They have a temperature, and we can also see how often they're getting the temperature and document that down. And that can be a data point. But what we're really looking at is the RDT.
Yes, and this is something for all remote providers, regardless of if you're thinking about malaria or any other disease. I think it's very valuable to track the fever pattern. Some diseases do have a characteristic fever pattern, not just malaria. So dengue has a fever pattern, and there's a number of other diseases that do that. So again, that's a good data point. And if the practitioner has a reference that they can look at and see, okay, I've got this fever spike, and this is my list of my differential diagnosis list. Does that fit this disease or that disease? And then, of course, if they have communications, they can call perhaps an infectious diseases doc and run all this data by them and see what they think.
So we've done a deep dive into malaria, and we've talked about how to treat it, how to assess it. Let's talk about nipping the whole thing in the bud and get a vaccine. So we have 2 vaccines at the moment. So and a brand new one that just came out. So let's chat about vaccines.
Yeah. So I've got I found a paper recently that was published in Malaria Journal. So the aptly named Malaria Journal here. And again, this the title is a perspective on Oxford's R21 Matrix M malaria vaccine and the future of global eradication efforts. We've got first author Nicholas Aderinto, and the primary author here, Rebecca Ojabo, if I'm pronouncing that correctly. So this article appears to be little bit of a systematic review on where we're at right now with the R21 vaccine. So they have right here in the abstract. This is the newest information I've seen on the epidemiology of malaria. So in 2021, so during the COVID outbreak, we did see an increase in deaths globally. So it went up to 600,000 deaths. I think it was down in the 400,000s prior to that. So COVID obviously disrupted many things globally, healthcare infrastructure and, malaria eradication teams that may have had their, funding diverted into combating COVID-19 and things like that. So we had an increase in overall deaths in 2021 up to 600,000 and a total of, it says here, 247 million infections. And that's across 85 countries. Let's see here. So the R21 vaccine, like I said, this was WHO approved a couple years ago, and this was designed by University of Oxford and Novavax, and the efficacy is quite good, especially for a parasite vaccine. So it's 77% effective in their phase 2 clinical trials. And one of the issues I think that is kind of pertinent to the demographic of quorum is we look at infectious diseases, I think, through two lenses, right? We have, one lens is, okay, there are the local nationals that are, living with this disease where, their children are dying and it causes, it has a massive impact on the, indigenous populations in many of these countries, mainly in Africa, but also to a lesser degree in Asia and South America. So that's one lens that we're looking at this through, and this is the lens that most research is looking at malaria through, and rightly so. We're talking about 600,000 deaths a year, and the vast majority of those are very young children, mainly in Africa, where you have the worst of the species of malaria, the Plasmodium falciparum. And so we're seeing the vast majority of these deaths in very small children, and the main reason for that has to do with the immune system of these children. So these are children under the age of 5 or under the age of 3 who have, the children are born with very immature immune systems, and it takes a little while for that immune system to ramp up. And if the infant is being breastfed, then they do get the benefit of maternal antibodies being passed through the breast milk. So for that period of time, they're mostly, not 100%, they're mostly immune to malaria. Now, once they wean off the breast milk, they're sort of on their own from an immune standpoint. And this is the most vulnerable population in terms of malaria, right? So that's where all the public health efforts are focused for the most part. So on that demographic. So that's one lens that we look at this malaria issue through. The other lens that we look at through is, well, what about adults that are in this area, particularly adults that have never had any exposure to malaria? So this is going to be the vast majority of students that go through quorum courses. So they're people from Europe, from North America, predominantly, where there's not a whole lot of malaria, and they're going through our training in preparation for going and working in Africa, going and working in Asia and places like that. So what about these adults that are malaria naive? They go to sub-Saharan Africa, where malaria is most predominant, and these folks are hopefully taking their malaria prophylaxis, chemoprophylaxis. Chemoprophylaxis, just like the RDTs, are not 100%. So you can be taking Malarone, you can be taking doxycycline, mefloquine, any of those things, and still get malaria. So the issue that I want to focus on here a little bit is what about adults receiving malaria vaccine? Is that something that's on the table?
I can understand that, of course, it's got to be kids that gets the first crack at this because they're the highest risk. So I don't mind not getting one when I go to Tanzania and Ghana because, I mean, that jab needs to go to the kids, doesn't it?
Yeah, absolutely. And as the R21 vaccine rolls out more and more, and it becomes, it just becomes like a standard vaccine, like like a polio or a measles vaccine or something like that. Like once we get to the point where there's enough vaccines to go around for all the children and everything like that, people are going to be asking more and more, like, hey, what about my team that I'm going into Africa with? Should we get the malaria vaccine, or can we get the malaria vaccine? So the WHO recommendation for the R21 vaccine is currently it's only for let's see here, children under the age of 3. I'm just looking for I'm trying to see if there's a little bit more clarification on that. Yeah, so they do talk here about the RTSS vaccine, which is partially effective, and we do have a much higher efficacy, like I said, with the R21 vaccine. So in this particular article, they don't talk about clinical trials for adults or anything along those lines. But last year in Thailand, and I think this has been done in a couple other places, they have started doing clinical trials on the R21 vaccine in adults. So they are anticipating a day when, number one, we're getting all the kids vaccinated that need vaccines, and then number two, once we start really thinking about vaccinating adults, we want to be on top of that, so we can say, yes, this works for adults, and we recommend this this individual that's traveling into rural Burma gets this vaccine, or well, it's only 30% effective in adults, so it's probably not worth it.
So that's a good point. So let's say that this is 77% success rate for adults as well, and we get to the point where it's ubiquitous, everyone has it, and I take that. Am I still going to be on Malarone?
Exactly, and that would that would be I guess a logical part of the studies is you have your control group, and then you have different arms of the experimental group. So you've got this would be a phase 3 trial where we're deploying it into a country in thousands of people, and we want to get data on so adults that got this vaccine, that only got the vaccine, how much of them, or how many of them got malaria, and as opposed to another group of adults who they got the vaccine and they were taking Malarone, or they were taking doxycycline, etc. So I think those studies will eventually come together.
Well, I'm looking forward to seeing an end to this. As much as I love malaria and looking at it under a microscope, I do hope that the days are numbered of that little wee beastie.
Amen to that.
So what advice do you have for someone who wants to learn a bit more about malaria?
Well, I would say, read the literature. It's anything medical these days is a pretty fast moving ship. So I think every day that goes by, it gets more and more challenging to kind of stay abreast of the latest and greatest. So, read the literature and, get what training you can, and, look at, before you deploy to any of these places, I would definitely look at the World Health Organization website, and as well as the CDC. You're going to get some good real time information on recommendations on what types of RDTs you can use, what type of insect repellent is going to be useful in this particular part of the world, what kind of chemoprophylaxis is working, and what kind of malaria treatments are working.
So the World Health Organization and the CDC.
Yeah, that would be the main ones. And there's another one. This one's so there's another website called ProMed. So it's spelled PROMED. And I recommend that to anyone that's traveling to less sort of industrialized countries, or even countries that are industrialized, like if you're going to Russia or the US or anywhere like that. ProMed will give you, it basically has a daily log of disease outbreaks. So you can log in today and see something like, oh, there was a case of bubonic plague in Arizona here in the US, and it was like, one patient or something like that. Or there was an outbreak of tuberculosis in this village in Siberia. So if you're looking for sort of like real-time intel on outbreaks, particularly things like filoviruses, right, Ebola and Marburg and things like that, if you're going to that part of the world, ProMed is a really good source of intel.
Well, and you can also say go to London School of Hygiene and Tropical Medicine and take their diploma in tropical nursing, or come to Malta and do the tropical travel expedition medicine course. There's tons of options out there, but the most important thing is be safe, educate yourself, and be a better medic.
That's it.
Jason, it's great to have you here again. We try to get you in every 3 months, sober you up enough so you can have a good chat about tropical diseases.
All right. Well, thanks for having me.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.